Good afternoon, everyone, and welcome to the second presentation of the patient behind the screen, status asthmaticus and life-threatening asthma. The information provided in this presentation is for educational and informational purposes only and is not intended as medical advice. This presentation is part of our efforts at Inspire Respiratory Critical Care, where we provide weekly podcasts called The Gas Exchange, expert panel discussions, weekly pearls, virtual classroom lectures, and other educational initiatives. You can find recordings of our podcast on YouTube, Spotify, and Apple Podcasts. Recording of our panel discussions can also be found on YouTube. On our website, inspire-rt.com, you can find links to our past recordings and many other resources. My name is Marjorie Cullinan, and I will be presenting the simulation scenario for this episode. This is an interactive session, so we will be using QR codes and links for audience participation. And please place any questions that you have in the chat on the right-hand side of your screen. We will address questions from the chat at the end of the session. So welcome, everyone. Want to provide for you a slide here that we are going to be using a format called Slido for our interactive portion of the presentation. You can take a picture of this QR code, as well as we go through the questions, the QR code will appear. You can also, if you already have the Slido app, you can use the number to access it. As you're accessing it right now, you should see nothing on the screen, and that is normal until we get to a question. The question will appear when we get to that slide, and then also the statistics and the information that you input will appear on the screen as well as on your phone or tablet, whatever you're using to utilize Slido. So we'd like to introduce you to our simulation scenario. So you're receiving shift report, and the outgoing respiratory therapist tells you that there is a 20-year-old male who is in the ED with severe shortness of breath, chest tightness, and wheezing. In terms of medical history, there's not really much there. He has one very vague prior asthma-like episode and has never seen a pulmonologist. There's no formal asthma diagnosis, but he had an exposure to something like an allergen about 24 hours ago and has had increasing distress and symptoms since then. He did borrow an inhaler from his family member. We have no idea if he took it properly, how many puffs he took, but really it was with minimal relief and he presented to the ED. In the RT that is giving you report in their assessment, they feel like this is a severe asthma exacerbation, that the patient is in status asthmaticus. And this is a persistent respiratory distress that isn't getting better anytime soon. The patient has had an ongoing need for continuous bronchodilator therapy and is currently on and would like to continue continuous albuterol at 20 milligrams per hour, ipratropium bromide given intermittently throughout their course. Systemic corticosteroids are definitely needed. This guy is really not breathing well, and he is going to be receiving magnesium sulfate. So you get this report, this guy's not doing well, and you head down to the ED, and this is what he's looking like. He is anxious and visibly diaphoretic through his Johnny coat. He's in the tripod position, only able to answer your questions in 1 to 2 words. He's tachycardic. He's on oxygen through that continuous nebulizer, and his SpO2 is 86. He's breathing very rapidly and has marked accessory use. Even with a normal physique, he has normal musculature, but you can really see that he's using his respiratory muscles. When you auscultate his chest, he has diffuse inspiratory and expiratory wheezing with a very prolonged expiratory phase, and he is diminished at the bases, losing the ability to move air with every breath. He has those intercostal and substernal retractions and a very high work of breathing. With that, between the shift report and what you're seeing with this gentleman, you decide to put him on some BiPAP, and he's tuckering out. Our gentleman is now not answering questions. You're up titrating his BiPAP settings and obtain an ABG. He is becoming acidotic, and just if you look at your blood gas, you can see his CO2 is rising. Even the look in his eyes, he is not able to maintain this type of respiratory work. He's on 80% oxygen, and his SaO2 is 87%. It is no longer adequate to be able to continue on this course. So we're going to ask our first question. So if you scan the QR code or just go into the Slido that you have already opened, what should we do next for this gentleman? Should we be initiating Heliox? Should we increase his NIV settings more? Should we be intubating with etomidate or intubating with ketamine? So think about that for a moment. What would you like to do? And let's see what we're getting for answers. I'll give another couple moments for folks to weigh in. All right. Very good. Thank you all for your answers. So we have the majority of our crew definitely wants to intubate, right? Take the respiratory work off of this young gentleman. We did have a couple of answers of Heliox or NIV settings. Heliox, as we know, would be difficult to introduce into the system, or we'd be taking away some positive pressure. Do we have room to move up in our NIV settings? But I think in general, we are headed toward helping this gentleman with invasive mechanical ventilation. When it comes to the agent that we're using in this intubation, ketamine is a better choice in asthma. And it is a better choice because it does have the ability to relax the smooth muscle, which we know is a problem in asthma. And we will discuss that in our pearls, as well as it has an anti-inflammatory effect. So a bit of a bonus as an agent during intubation, because it can actually help some of the underlying defect that's happening in the acute asthma exacerbation. So here's our intubation scenario. The gentleman is on BiPAP as a bridge, and our team is preparing to intubate. His vital signs are in the background as he is worsening. So after intubation, we're able to take a look at our ventilator, and our patient is initiating breaths over the vent. We have him on volume control, a rate of 20, tidal volume 500, PEEP of 5, and 100% FiO2. We did do a expiratory hold to find that he does have some auto PEEP also in this scenario, and he is not fully exhaling out his volume. So after looking at the ventilator, we take a look up at the vital signs monitor, and we have a blood pressure that has softened quite a bit. And that did necessitate the use of a vasopressor in the form of norepinephrine. We did get an arterial blood gas on our vent settings, and you can view them there in your assessment of our ability to ventilate and oxygenate. And based on this information, both the ventilator, the blood gas, and also the need for vasopressor support, we ask our next question. So in this overall assessment after intubation, what would you recommend at this time? Decreasing the set respiratory rate, increasing the tidal volume, initiate sedation and a paralytic, or increase the albuterol dose, which from the original part of our scenario was 20 milligrams per hour. So I'll give you a moment to answer. All right, some answers are still coming in. All right, so I think we have a consensus that increasing the tidal volume and increasing the albuterol dose are not what we're going to want to do right now. And overall, I think in general, we want to bring that respiratory rate down in order to allow the patient to exhale more. But do we want to do that by decreasing the mechanical rate of the ventilator? Or do we want to do that by taking the patient out of the initiating of breaths first, so then we can decrease the set respiratory rate? So at this point in the simulation, we would prefer that we initiate some sedation and a paralytic agent so that the respiratory therapist and the medical team are now in control of the respiratory rate. So we have our ventilator screen. So now the patient is on that set respiratory rate of 20. We are only breathing 20, and we do an auto PEEP maneuver to see that our auto PEEP is somewhere around 12 or so. So with the patient taken out of the scenario in terms of their initiation of breaths, we have better control of their exhalation and therefore can drive whether they are generating auto PEEP with the rate that they're on right now. So you go into the medical record to take a comprehensive look at what's been going on. So we have our initial blood gas, which is at 1530. That is post intubation on a rate of 20, but breathing at 24. And then we now have all of our assessment abilities at 1500, or sorry, at 1700 with the patient taken out of the scenario. So with these vital signs that we see here, the things that are of the greatest concern are the blood pressure, which is very soft, and the need for a pretty high level of a vasopressor. So we have Levophed as our vasopressor, norepinephrine, and we have adequate oxygenation at this moment. But really, what we want to look at is their hemodynamic status. So it brings us to our next question, which is, what is the most likely cause of hemodynamic instability? And instead of taking a poll for this question, we're going to do a thought cloud. I would like you to type in reasons, and you can come up with multiple reasons why you think that this gentleman in status asthmaticus is having a hemodynamic problem at this moment. So type in some answers, and we're gonna take a look at what the group thinks. All right. I think you guys are all on the right track, right? So we have an individual with otherwise normal physiology, right? He has acute bronchospasm, and that is causing air trapping in the lungs. We started off probably with our patient having air trapping before we ever introduced positive pressure. And now, in the fact that we're trying to save his life with a mechanical ventilator, we may actually be making it worse. And what we want to do is to help to treat that dynamic hyperinflation. It's such a great series of words. It's happening right now. We can actually be causing it to be more by putting positive pressure into the system. And we can compromise the cardiovascular system by our interventions on the mechanical ventilator. All right, do we have any more contributions? You guys did a really great job on this one. So much so we may do more thought clouds in the future. You guys have a lot of great thoughts. So with that dynamic hyperinflation, with that auto PEEP, with that decreased venous return, what would you recommend for continued mechanical ventilation of this patient? Would you decrease the respiratory rate, increase the tidal volume, wean the sedation that we had put on earlier, increase the albuterol dose, or maintain the current ventilator settings? So put your answers into Slido. You guys are getting faster. This is great. All right, let's see what our answers are. Oh my goodness, you guys are awesome. So in our last intervention, we took the patient's effort out of the scenario, and we now, as the respiratory therapist, have the control of their respiratory rate. So absolutely, we want to decrease the set respiratory rate and allow for more expiratory time, allow for air to leave the chest so that we don't have that hyperinflation, so that we aren't compromising the cardiovascular system. So we're going to decrease the respiratory rate. And our ventilator screen now, we are now on a respiratory rate of 12. We do an expiratory hold, and we have gone from an auto PEEP of 12 to an auto PEEP of 9. So we are in a better place. So after that decrease in respiratory rate, we take a look in the medical record, and we've made the change on the vent, and his hemodynamics are improving. Our blood pressure has improved, and we're using less of our norepinephrine. So they were able to bring the dose down from 18 micrograms down to 12. So better. After another couple of hours, we can't help but get a blood gas because we're RTs. So we look at his vital signs. We see that his blood pressure is still doing well, but we're still hypercarbic. And, oftentimes that can give us a pause, but we're on lower pressors. Once again, we're able to titrate that pressor dose down. So with this blood gas and the vital signs that you see there, what would be your next move? So he's currently on a rate of 12. Would you decrease that further? So decrease the set respiratory rate. He's not breathing over the vent. Would you increase the tidal volume? Would you wean the sedation? Would you increase the albuterol dose? Or would you maintain the current ventilator settings? So let's enter your answers into Slido. All right. All right. Thank you all for your answers. So we have a bit of a split on the consensus of our answers. So the majority of folks said maintain current ventilator settings. And I think that as bedside RTs, oftentimes we're perfectly happy with a good blood pressure, and we gain some discomfort from going down on our respiratory rate when we start talking less than 12, less than 10. But the most important piece of allowing for someone with acute status asthmaticus on a ventilator to heal and to recover from their the acute process that's happening is to be able to protect the lung as much as possible. And the recommendation is to continue to decrease the respiratory rate until they have exhaled most of their volume. At this point, this gentleman still has an auto PEEP of 9. I know in a lot of scenarios, folks would go, auto PEEP of 9 is no big deal. But for someone who is trapping air dynamically, we want to continue to decrease that set respiratory rate, even to a point where the blood gas is more hypercarbic than we're comfortable with. And we want to ensure that his hemodynamic stability is maintained throughout his weaning, throughout the acute course, so that this otherwise healthy gentleman walks out of the hospital also otherwise healthy after his acute exacerbation. So our recommendation as the Inspire team is to continue to decrease the set respiratory rate. So this is a patient who is only breathing at a rate of 8 breaths per minute. In his expiratory hold, he has an auto PEEP that is a total of 7. So truly exhaling most of his volume and not trapping that air that we're pushing into his lungs in order to protect them. Remember, permissive hypercapnia is a strategy to be used in order to protect the lung in acute asthma and other processes. So we emphasize that once you have control of the ventilator, that the patient is no longer breathing, we want to bring that rate down, allow the patient to exhale, try to eliminate as much of that dynamic airway hyperinflation as possible so that we can stabilize the patient as much as we can. If you observe the EMR screen once again, we now have a hemodynamically stable patient with permissive hypercapnia and no pressors being used to maintain his hemodynamic status. Now, this was a scenario of a pretty long shift. Oftentimes, not all of this can be accomplished in a 12-hour shift, if not 24 hours or 48 hours or several days, depending upon how long it takes for their acute exacerbation to resolve. But we're going to take the different pieces that we just got from that scenario, and we're now going to transition into the clinical pearls of the simulation. And at this point, I would like to introduce Keith Lamb. He is the CEO and president of Inspire Respiratory Critical Care to present the different clinical pearls that we can take from this simulation. Keith?
Thanks, Marjorie, and thanks to all of you for participating today. I'm super excited about all the. We're definitely gonna have to use the thought bubbles again. We got a lot of really good participation there.
Mm-hmm.
So as we know, when a patient has severe asthma, there are 4 major components at work. The primary one is bronchoconstriction or reactive airways. And we know that a reactive airway gets smaller and the caliber gets smaller, and resistance imposed upon that smaller caliber airway causes the patient problems. We know that in addition to the reactive airway and the bronchospasm and the bronchoconstriction, there's also airway inflammation, an extreme exaggerated inflammatory process, which is really part of the whole scheme of asthma. And so along with the bronchospasm, airway inflammation, and part of that inflammatory process is the hypersecretion of mucus, which also gets in the way of the movement of air. And as a result of all those three major components above, we will have dynamic hyperinflation. And this comes in the form of air trapping. And we'll talk a little bit more about why that's the most significant part of an asthmatic sequela. So pharmacology is your friend. Pharmacology is your primary attack phase here with a patient that's got status asthmaticus. The first phase would be to aggressively provide bronchodilators, and typically in the form of albuterol and atropine or ipratropium bromide. You for sure need, so that would treat the bronchospasm and the reactive airways, systemic corticosteroids for the inflammatory to mitigate the inflammatory process. IV magnesium. Magnesium also promotes muscle relaxation and is a mild anti-inflammatory. And when these things aren't working, then we can implement the use of refractory adjuncts such as the use of ketamine. Marjorie mentioned the use of ketamine during the intubation because it has some bronchodilatory effect. Heliox, which is a lighter gas that promotes the easier movement of gas. Leukotriene antagonists and interleukin-5 biologics. Biologics are sometimes used in the critical phase of asthma, but primarily used in the prevention of the status asthmaticus. So you really have to pay attention to the patient. Now, I know that we preach anybody that takes care of patients and is involved in education preaches that you really got to pay attention to that patient. That's your primary objective, and you can tell a lot by just watching the patient and doing a really good physical exam. So don't just look at the numbers, particularly the blood gas. Marjorie mentioned that as RTs that we love to do blood gases, and we are certainly the experts in interpreting the data and the information that we get from doing a blood gas. However, I would really implore you to not be concerned about a blood gas in this particular case. This is asthma is primarily a single organ failure disease, and in single organ failure, your CO2 and your pH probably are not as important as the physiologic sequelae that occur from air trapping. So as you're watching your patient, you'll notice if you really need to, no matter what your intervention is going to be, you don't want it to be delayed. We know that delaying definitive intervention causes a precipitous worsening of outcomes. And so it's really important that you watch this patient, and as they slow their respiratory rate down, from a physiological standpoint, a patient that's got gas exchange problems should breathe faster, right? Their neuro impulses are telling them that they should be breathing faster, they should be breathing deeper. So if you have a person that's in acute respiratory failure, hypercarbic or type 2 respiratory failure, and they're slowing their rate down, then that's because they're getting tired, right? And so that's going to be one of your primary physical exam traits. Altered mental status, your patient came in not really able to communicate well, but certainly able to respond by shaking their head or giving you a thumbs up or thumbs down. Then that's probably a typical neurostatus, but as that gets worse and patients are unable to cooperate with their treatment, and unable to and getting agitated, then that's a sign that things are not getting better, and that you probably should be doing something different. Somebody an asthmatic gets hypoxemic, that's typically a late sign. And as somebody is getting, an asthmatic is getting hypoxemic, then that's sort of ominous. Does non-invasive positive pressure ventilation have a role in severe asthma? I would suggest that you look at the literature. Over the last few weeks, we have provided pearls on a weekly basis that have the PMID numbers associated with them, so that you can look these things up. Again, your primary objective is not to delay intervention, definitive intervention for somebody that's in respiratory failure and is losing speed here. So you need to really pay attention to your physical exam to determine whether or not it's worth delaying something else by placing a patient on non-invasive ventilation. You typically can just use your physical exam. Why does non-invasive ventilation help when it does? In severe asthma, we know that we talked about the inflammatory process. We talked about the reactive airways. We talked about the sequela from that being air trapping and dynamic hyperinflation. We're going to talk more about why somebody goes into shock and hypoperfusion and hypotension here in a moment. But those are the reasons why. And so when this happens, when somebody becomes hyperinflated, then your basic physiologic methods to breathing are impaired. And this causes an increased work of breathing. You have respiratory muscle fatigue. And then because you have respiratory muscle fatigue, then that's the patient that will get a slower respiratory rate, will look more fatigued, will have the inability to communicate with you even more. And if you initiate non-invasive ventilation, then this could certainly, in some cases, unload respiratory muscles and avoid that muscle fatigue. It could offset some of the auto-PEEP, and it for sure will support ventilation at some level. However, it's positive pressure, and it can also impinge upon you hemodynamically, just like invasive mechanical ventilation can. So what does this mean in practice? If you look at the data in the literature, it's been associated with lower subsequent intubation in adults and pediatric patients. And some of the data suggests that in-hospital mortality is lower. In pediatrics, mortality trended in the same direction, but was not statistically significant. How to use it? Again, physical exam is really your primary tool. So the data supports considering non-invasive ventilation in ICU patients with severe asthma exacerbation. You have to monitor very closely. You have to do frequent neuroexaminations. You have to be very careful about delaying definitive intervention, like we've mentioned a couple times. Now, what do you want to make sure that you don't miss in the data here? Is one of the things is this is all observational data. These are not a robust prospective randomized controlled trials. Don't let non-invasive ventilation delay needed endotracheal intubation, and take caution in patients with poor physiologic reserve, severe respiratory acidosis, or hemodynamic instability. The perils of intubation. I mean, there are several. When you intubate somebody, you do a rapid sequence induction and you give them medicines that are going to contribute to their shock, in addition to the positive pressure itself that you introduce into the pulmonary system. Intubation and near fatal asthma is a very high risk event because the patient is very unstable to begin with. And when all of the drugs that you give the patient to intubate them kick in, that's going to contribute to the hypotension, and then all of the mechanisms for dropping blood pressure with positive pressure then occur. And I forget the person's name who put the comment in the comment box while Marjorie was presenting, but yes, you at some time there may be times where you need to disconnect the patient from the ventilator and push on their chest to get some of that air trapping out. So in normal cardiopulmonary physiology and hemodynamics, you have your right atrial, left atrial pressure, right ventricular pressure, left ventricular pressure, cardiac output, ejection fraction, etc. When you introduce the positive pressure, multiple things happen. First, you decrease venous return. So if you have all the pressure in your chest, that slows down or reduces the amount of venous blood that returns to the heart. Your right ventricular afterload or will decrease or increase rather, and the afterload is the resistance that the cardiac that the blood volume goes from the right side to the left side. That's caused by all those alveoli, primarily caused by all those alveoli being compressing against the pulmonary vasculature and the capillaries, and you can have right ventricular failure from that in some cases, but for sure you have less blood coming back to the left side of the heart. If you have less blood being returned to the left side of the heart, in conjunction with that hyperinflation compressing the left ventricle, all of those things concomitantly will for sure decrease your cardiac output and drop your blood pressure. So ventilating severe asthma does not follow the standard approach. One of our listeners, Rena, mentioned this in the comments a little while ago. And so the primary reason for this is exhalation, right? Again, I told you that in most cases, hypoxemia is sort of a late sign of respiratory failure in asthma, acute asthma emergencies. The problem is that it's not the gas exchange itself, it's the compression of the pulmonary capillaries and the decrease in blood pressure. And again, the exhalation is the problem, right? You put the air goes in, the same amount of air does not come out. So those alveoli, those 300 million alveoli just get bigger and compress all the pulmonary vasculature and do all of the other things that we just mentioned in the hemodynamic slide, and your blood pressure will drop. So the root cause of all of this is prolonged expiratory time constant. And we know that in patients that are asthmatics, that they're, because of their airway edema, because of their hyperproduction of mucus, and because of their reactive airways that are constricted, all of those things will increase the resistance, the airway resistance, and an increased airway resistance in a patient that is relying fundamentally on their own respiratory physiology and capabilities will become hyperinflated again, and this will impair their standard respiratory function. We know that an asthmatic patient, like some other patients, that their pulmonary regions or their gas, their pulmonary regions are not homogeneous, and so you may have some relatively normal function in one part of the lung. Another part of the lung can be plugged, and you can have a significant VQ mismatch from having a mucus plug off a lobe. You for sure have this hyperinflation in some other areas, and so this will cause you to have gas trapping. Will also change your VQ matching and cause all of the negative sequelae that we've mentioned already. So there's not one way of treating this patient necessarily. This incomplete emptying produces a dynamic hyperinflation and autopeep. All of you guys did a great job of recognizing that in this scenario. This hyperinflation and autopeep is the crux of the problem in an asthmatic. And that's what we really want to make sure that everybody goes home with. And that is that, if you watch blood gases, you may be, and I'm sure you've all seen this, if you've been doing this long enough, you'll see a patient that gets a 7.2 blood gas with a CO2 of 90, and somebody wants to turn the rate up. And so what we want you to get from this, and what we really want to emphasize, is that this is single organ failure. Single organ failure patients like asthmatics will tolerate in a remarkable way high CO2s and low pHs. What they will not tolerate is complete hemodynamic collapse, right? These images here show you another sequela of significant hyperinflation, and that is that you can have alveolar rupture, and you can have an acute pneumothorax, air in the pleural space, and that can also impinge on all of the things that we just talked about. If you have a significant pneumothorax with tension physiology, then you can very easily have a patient that is arresting in front of you. So in this particular patient subcategory, severe asthmatic, when the carbon dioxide rises, this is a sign that you, along with hemodynamic instability, like our patient that had a norepi requirement from hypotension, then you need to do something that will decrease the opportunity for trapping gas. And the way that we demonstrated you do that in our scenario is that you drop the set respiratory rate. And if that's not an option, or if that's not going to help, then you drop the rate by taking full control of the patient, right? Sedation and neuromuscular blockade. So dropping the rate and allowing for longer expiratory time is the way to approach a patient that is hemodynamically unstable. So this is just another explanation of why this is true. You need to give the lung time to empty, and if a patient is spontaneously breathing, it's unlikely they're going to be able to do this. Again, the patient's natural physiological response is to breathe faster, and in this case, this is going to have counterintuitive response. And so you need to decrease the rate. You can sometimes give a smaller tidal volume. You can sometimes make changes in the ventilator. You can shorten the I time. You can increase the inspiratory flow. However, these results pale in comparison to just dropping the respiratory rate. You get way much more bang for your buck. Other things you should be paying attention to, flow time waveforms. And you can watch the waveforms to see if there's emptying of the lungs. You watch plateau pressure. As you empty the lungs, as you do a better job of emptying the lungs, your plateau pressure should simultaneously come down. You can also, like Jared put into the comments, that the difference between your peak pressure and your plateau pressure is a good indication that your resistance is either going up or it's going down. And so you need to monitor those things. You need to monitor intrinsic or auto PEEP and make sure that that's going away. And if you do all of these things, then you are likely to improve venous return. You are likely to improve cardiac output, and you're likely to save this patient's life.
So you may be thinking right now, we've been talking a lot about decreasing the rate, allowing for more time to exhale. And how did we come to decreasing the rate as much as we did in our simulation? So I would like at this point to transition to our presenter, Eric Kreiner, who is going to talk to us about tau and time constants and how we can actually determine how much we're going to be turning down that rate, how much we're going to be titrating that rate to allow for our patient to fully, or as fully as possible, exhale. So welcome, Eric.
All right. Thank you, Marjorie. Just give me a quick confirmation that you're seeing my slides, because I lost you guys.
Yes.
Okay, great. Perfect. All right. So I'm going to walk us through, I guess, the pragmatic and practical approach to dropping the respiratory rate according to a patient's expiratory time constant. So we talk a lot about personalizing mechanical ventilation for ARDS patients. And this is one step in the direction of personalizing mechanical ventilation for an obstructive disease patient. So what I have here for you, is a pressure time and a flow time scaler here. I will kind of quickly identify, at fundamental levels, there's our inspiratory time and there's our expiratory time. And it begs the question, kind of out loud, it's not a poll question, but it begs this question. What are the ventilator parameters that determine the time allowed for expiration? I sometimes like to think about it, or what is the ventilator's expiratory time? We are really wrapped up in the patients, but when it comes to setting up the ventilator, you need to make sure that and ensure that you have enough expiratory time. And so if I have an I time set up 1 second, whether that is a combination of volume and flow that you directly set, or you're setting I time directly, and a total respiratory rate of 20, mathematically you arrive at the expiratory time from what is left over, essentially. So the total cycle time, or what some people may call the breath-to-breath time, is 60 divided by the rate, which is 20 here. So my cycle time is 3 seconds. And if I subtract the inspiratory portion from that total cycle time, I arrive at the expiratory time of 2 seconds. If I alter that respiratory rate a little bit, in this case, the respiratory rate is 30, the I time isn't changing. And what you can see here is that as the rate increases, the cycle time decreases. And as a result, my time for exhalation allowed goes downwards. And so this is the premise in reverse of what we kind of set out to do with the ventilator in decreasing the set respiratory rate. So if I have this in mind, what is it that determines the ventilator's expiratory time? I think the next logical question is, what is it that determines the patient's expiratory time? Because these things have to line up, right? If I don't allow enough time for the patient to exhale based on what I have set up, I'm going to have the result of air trapping. So what is the physiology, or what are those parameters that determine the time it takes for the patient to expire, right? And so this is what we're really concentrating on here. I have a volume time scaler. I have highlighted just the expiratory component of it, because this is what I'm working on here, is how much time is it going to require the patient to exhale. So if I draw this expiratory volume time curve, it would look a little something like this. This isn't a normal patient, right? And so it has this exponential decay. And based on physiology, that volume time curve, that shape of it, is determined by the natural decay equation. It is this big, ugly equation. I have it there. There's a lot of division. There's even an exponent involved in it. And so this isn't something that you're going to go about calculating at the bedside or anything like that. It is the physiologic principle of this. And so as we break down the natural decay equation, which is telling us how long it's going to take the patient to exhale, the components of it we can break it into the components. And VI really, it stands for the volume at any point in time along exhalation.